Hi, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai, I'm the JAMA Fishbein Fellow.
Of course, if you're following along live, please feel free to send us questions or comments on Twitter at JAMA Network Open or respond in the comments on Facebook or YouTube. Today, our first paper is the associations between social risk factors and surgical site infections after colectomy and abdominal hysterectomy. And we've got senior author Dr. Karen Joy-Maddox with us. Welcome.
Hi, good afternoon. Thanks for having me.
Sure, thanks. Glad you could join us. So why don't you tell our viewers a little bit about what you did here in the paper, or about yourself and what you did here in the paper?
Sure. So I'm a cardiologist at WashU and also a health policy researcher. So one could wonder, why did we do a study on surgical site infections? Because I haven't been in an OR since med school. But the reason that we did is because this is actually an important policy issue right now. So there's a lot of new payment programs in Medicare and with private payers too, that evaluate hospitals on their infection rates. And so a question that we had was whether or not social risk factors like poverty or Medicaid insurance or race and ethnicity might actually be associated with different, higher, in this case, rates of surgical site infection that then could potentially penalize hospitals for factors beyond their control when it comes to their evaluation on these metrics. So it's sort of a policy-driven paper with a very clinical question, which is essentially looking at the relationship between patient characteristics and surgical site infection.
Right. Okay, and then it looks like you used a bunch of state databases to link the OR data with the infections. Tell us what you found.
Yeah, so we used state databases that allowed us to follow patients over time. So we didn't have all the states in the country, but a pretty reasonable sample. And we looked to see whether or not patients who were living in poor neighborhoods, those who were insured by Medicaid as a marker for individual poverty, or those who were a minority race or ethnicity had higher infection rates after colectomy and hysterectomy, which are two of the main surgical procedures that are included in these quality measures. So certainly not representative of all the surgeries in a hospital, but they're the ones that many hospitals are judged on. And we found that the patterns are actually a little different for the two surgeries. So for colectomy, the overall infection rate was just over 2.5%. It was actually lower among Black compared to white patients, but higher among patients with Medicaid versus private insurance, and higher for those living in low-income neighborhoods. So for colectomy, we found that both individual poverty and neighborhood poverty were associated with higher infection rates. For hysterectomy, which is sort of a younger, healthier population, as you can imagine, the overall infection rate was lower, so only about 0.6%. And in this case, we didn't find any statistically significant relationships between race, ethnicity, individual poverty, or neighborhood poverty and surgical site infection for this procedure.
I'm curious, what do you think? Do you think that the lack of finding any statistically significant differences in the hysterectomy group was just because the rates were so much lower that it's harder to find a difference, or do you think there really is no differences there?
You know, it's hard to say. I hate to sort of say low sample size because our confidence intervals are close to 1 and all that. I think you can sort of take the confidence intervals for what they are. It is just such a different population in terms of overall health and comorbidities that luckily the infection rate is quite low. That gives it a bunch of different challenges in terms of using it as a quality measure, as you can imagine. But certainly in this case, either we were underpowered or the relationships just aren't as strong.
Right, and I'm trying to be an optimist. I think, despite all our health systems failings, we're actually pretty good at making sure that all pregnant women are plugged into some sort of coverage. Not perfect, and there's failings.
Yes, the colectomy population is pretty different. So the colectomy population, we had a lot of folks who are Medicare, Medicaid. It's an older population, lots of comorbidities, and really much higher rates of complications in general. So in that case, we saw stronger relationships and ones that went in the direction that we thought we might have found. Obviously, it's always disappointing to find disparities, but in this case, our hypothesis was that poverty would be associated with higher infection rates, and we did see that played out in the data.
Yeah. Was there a reason, I think, and you may have alluded to it already, that you chose to focus on colectomies and hysterectomies? Is that just kind of where the data is in order to do this type of analysis, or
Yeah, that's a good question. So in the Hospital Acquired Conditions Reduction Program, which is part of the alphabet soup of hospital value-based payment, there are a set of specific surgeries that are subject to the surgical site infection quality measurement, and these are two of them. So this is basically what the government uses to measure surgical site infections. A lot of these are tracked through NHSN, which is the National Healthcare Safety Network, I think, which is a CDC run program that does infection tracking, both for surgical site infections and other things like urinary tract infections, catheter-associated bloodstream infections, those sorts of things. So in this case, we were going where the data are used for the policy purposes, as opposed to looking at surgical infections more broadly.
Yeah, that makes sense. I think about surgical site infections a lot, but I've never thought about it in this way. So, and I think you mentioned a little bit about sort of what piqued your interest in thinking about social risk factors in surgical site infections. Were there other things that kind of made you think about specifically thinking about social determinants of health in this way?
Yeah, so there was one prior study suggesting that the hospital-acquired conditions reduction program did penalize safety net hospitals and sort of larger, more complex hospitals more frequently. I also personally spent a couple years working in the government looking at value-based payment programs and social risks. So this is sort of an area that I had some exposure to there and wanted to follow it up with data outside Medicare, looking more broadly in one of these databases. So, we really are moving so much toward value across payment programs, and to do it well, risk adjustment needs to be done right. Otherwise, you're not really making fair comparisons. And so this is an area where there's been less research. I think it sounds plausible to say that there should be no relationship between social risk and infection. If something's hospital acquired, why should it matter whether someone was poor when they walked in the door? And so that's been some of the pushback against thinking about social risk in this setting. I guess, our argument would be that we know that patients who are poor, who live in low-income neighborhoods, actually have more exposure to drug-resistant organisms, for example, closer living quarters, higher prevalence of poorly controlled diabetes, asthma, other risk factors that would sort of, put people at risk for infections in general. That said, surgical site infections have a good literature behind what can be done to prevent them. So we also controlled for hospital characteristics and looked at hospital characteristics here because we wanted to make sure that we weren't just sort of giving hospitals a free pass that might have not been doing the things that they were supposed to do. And frankly, as with most things, it's probably a little bit of both.
Right. And that's, I think you're alluding to, or I don't know, this seems to resonate with a lot of the other discussions we've had kind of as a profession about how to adjust or whether or not to adjust for social determinants of health or social risk factors. Is it that better hospitals are in better areas, take care of patients with fewer social risk factors? Or are they cherry picking better patients or punishing hospitals that take care of poor patients because they have other risk factors? Or are we setting, a lower standard for those other, for patients who are more vulnerable? Before we get into that, I want to welcome some of the viewers we have. We have Liseth Mora, Mohammed, Hugo, and apologies for my pronunciation as always, Malike Mariam. So welcome all. We're talking about social risk factors and surgical site infections. It's been interesting. I think if I remember the data correctly, the first year or so of the readmissions reduction program, it was the hospitals that had, the safety net hospitals that got dinged the worst. And as we got better at adjusting, we got better at figuring out how to do it. But it's, there's I don't think we have enough bandwidth on the internet to talk about this.
No, it's an important argument, and it's certainly one for which you can understand both sides. I think it is laudable to say that we don't want to accept lower quality for patients who are vulnerable. I think the disconnect is between what's under providers' control and what's not. So certainly we should think it to be entirely unacceptable if worse quality care is delivered to people because they are poor or racial and ethnic minority. That said, no one hospital event is necessarily going to have perfect control over events that may happen to a patient because of comorbidities or because of, sort of a lifetime of a development of, that's why the National Kidney Association doesn't come out and say that we shouldn't adjust for kidney disease, because that would accept lower quality of care for kidney patients, right? No one hospitalization can overcome all the complexity that a patient brings to the table. So I think you can actually be very strongly in favor both of intentionally trying to improve care for vulnerable populations and ensuring that payment programs are fair when they try to take those things into account.
Right. One last thing that I found really interesting in your findings is usually we find basically race and other social risk factors kind of collinear, and here we found that the Black patients had lower rates of colectomy infections. What are your thoughts there?
So I don't know exactly what the reason is for that. It actually makes me worry a little bit about residual confounding, that, we don't have great clinical data in these databases, so we don't know if the indications for surgery might be subtly different. We also know from some other studies, for example, for heart failure, we know that African American patients have markedly lower mortality for heart failure hospitalizations. And again, it's a little bit unclear whether that's because we don't do a terrific job capturing the different types of heart failure, like HFpEF versus HFrEF, or normal ejection fraction versus not, or hypertensive heart disease. And I think it's feasible, given the variety of things that for which colectomy is performed and the very wide range of severity of illness, that we're sort of missing some underlying factors that are key here. So I think it's an area that could be dug into with a clinical database, where someone could actually get things like blood pressure and labs and why are the surgeries done. So I think this is all sort of hypothesis generating, but I hope that people, especially surgeons, might have some data where they could dig in a little bit more to the details.
Great. Well, I think before we get into a 6-hour discussion of clinical administrative databases, I think we should end it there. But thank you so much. This is a really fascinating paper. Thank you for coming on and joining us.
Thank you so much for having me.
Great. Take care. All right. So what do we have next, Angel?
All right. So we have an exploration of barriers, facilitators, and suggestions for improving electronic health record inbox-related usability, a qualitative analysis. So this was a qualitative study that looked at 25 physicians at 6 large healthcare organizations using 4 different EHR systems, and they really wanted to identify, just as the title suggests, what were some of the barriers and facilitators that make EHRs difficult or easy to use for administrative and clinical purposes. And they used something called a cognitive walkthrough, which I hadn't heard of before, but I love it. And essentially, it helps you understand a system's usability by walking through each step of a particular workflow. And I think that this type of method or model is really used specifically thinking about, electronic interfaces or even just sort of systems processes in general. But they ended up identifying 60 barriers, which I'm surprised about, but I'm also sort of not surprised about. 32 facilitators and 28 sort of suggestions for improving the EHR. And they were specifically, I should mention, specifically looking at the EHR inbox for physicians. And when they kind of went through the qualitative motions of the study, they found that physicians wanted overall fewer clicks, streamlined messages in their inboxes, more intuitive labs, which I actually love this point because I think it's so true. A lot of times in EHRs, and I've used a couple of different EHRs, the labs are listed alphabetically and not necessarily grouped in the order that would make sense clinically. So this was something that came up. And sort of an overall, I think, theme was really just limiting the clutter. There's just a lot that comes in through the inbox, and it's hard to really be able to work through all of the noise. And then also they wanted to sort of reduce messages of low relevance. And I think they grouped it into 5 different themes, and I believe we have the figure for that as well, just to kind of take a look at how they looked at this, and I think it was really interesting. Yeah, I thought it was fascinating. So those themes they had were cognitive load, message content, inbox interface design, message processing complexity, and team communication. Yep. And for me, this is fascinating. This is I'm very lucky in the ED. We generally don't have to deal with inboxes as much. I rarely get stuff that's not related to an encounter. Basically, almost all of the things that I have to do are co-signing notes, missing notes, or co-signing orders, and every now and then I get a message from a consultant about a patient I sent them, which actually usually I get alone a volume that's usually actually quite nice. Or it's something like I order the wrong kind of outpatient follow-up or something like that. It's nice. Or just co-signing orders. And for me, my happiest point is I usually get every time when I go to work, I get like a terrible number of like 60 things to do, and 3/4 of them are just co-signing orders. I can just click. It's very nice because they've already happened days before. Before we get back into a couple more people joining us, Mario, Francesco Marti, and Dr. Michael Perez. So welcome. We are talking about EHR inbox usability, qualitative study. And again, it's fascinating stuff. And again, one of the things to me that came out a lot of this was kind of signal to noise ratio. Yeah. And just how much, kind of fluff you have to dig through with it. And it's just EHRs are tough. They're really tough. And it's interesting because they were really specifically looking at the inbox and not even at other factors. And, physicians identified a lot of these challenges. cases. So it would be interesting to see sort of thinking about it in broader terms as well. But definitely a lot of areas for improvement. I think a lot of clinicians, we have various frustrations, levels of frustration with EHR. So I thought this was really helpful in terms of moving that conversation forward.
Yep, we've also got Mariam Naeem joining us, so welcome. But yeah, the other things like that came up, I think it was interesting how they were talking about how what relevant things could be pulled in with the messages. Like there was one comment in here about, there's this patient needs their cholesterol medication updated. It's like, it'd be useful if it just pulled in what their cholesterol levels were, what medication they were on, and whether, that it seems like a lot of that could be automated.
Because I think one of the issues is that you end up having to actually go into the chart and dig around. But, the purpose of the inbox is not just to alert you, but, a nice purpose would be if the information that you needed was readily available as well.
Yep. Absolutely. Same thing to extrapolate a little bit from my experience. When I'm working in the ER, we generally use the track board as our kind of home base, especially where I'm supervising residents. I try to do everything I can without going into the actual charts and just kind of live on the track board. And it's funny because when we have the junior residents, they tend to look on the sidebar view that shows things in the patient. And then as they become senior residents, usually we try to push them to look at this, I don't know what it's called, like this bottom bar view. And it's just like a slightly different difference, but it's just much, much better when you're managing multiple patients to have to go less and less into the charts and kind of stay at that 30,000 foot view.
Definitely. I don't think that they did, but correct me if I'm wrong. Did they look at did they sort of separate this by specialty? I don't think so. I think it was just a general.
Yeah, I think it was
primary care.
It was primary care and family medicine. I think there were 8 specialists, but this is all basically outpatient stuff. Right.
I wonder, if the various levels of frustration are different, or the areas of I wish this was better, or this is better. It kind of depends on what specialty you're into, but overall it seems like there's areas that we could work on. Right.
And I think one of the cliche statements people talk about these enterprise EHRs is that they're they're primarily billing software, not clinical software, and they're sold to the big medical center. So you don't get the kind of nuance that I need an ED, you need your ID clinic, you do when you're doing consults. Each setting is very different, and getting that different kind of clinical nuance is really, really tough.
Definitely.
And I remember when I was in residency, we had a smaller EHR before we moved to one of the big national ones, and the biggest thing wasn't that it was better software. It was that we had 2 clinical informaticists who worked in the department and had control of their software. So if I said, hey, Nick, I think we need a chest X-ray in this order set, he's like, what? You're the 3rd person that told me that. It's done.
That face-to-face is always helpful.
And just not having to go through this big hospital where it's now, this is now the 270th thing on the list to address, which is a big problem. Any other thoughts on this one?
No, I thought it was great.
It's tough, and it's just I've been involved in a couple of qualitative studies. It is hard work. You really have to go through those interviews and do stuff. So we're gonna get into the table of contents rundown. We've got Baron Mikes who's joined us. So first paper is one of yours. Go ahead.
Yes. So this is the Association of Supine Going to Sleep Position in Late Pregnancy with Reduced Birth Weight, a secondary analysis of an individual participant data, a meta-analysis. So this was, as the title alludes to, this was a secondary data analysis of a previous individual participant meta-analysis that had been done looking at pregnancy. And this was trying to sort of assess the association of going to sleep supine in late pregnancy and what the risk of reduced birth weight in the babies was, essentially. And I think the pathophysiology or the thought behind this is that when you go to sleep supine in late pregnancy, there is an association of decreased blood flow to the fetus. And I remember from my recent pregnancy, all of these recommendations don't do that. Although I will say it is pretty difficult to do that once you get into late pregnancy. But regardless, so this study looked at 1,760 women. Only about 3% of those women actually reported that they did go to sleep supine during the previous 1 to 4 weeks in late pregnancy, and that was defined as after, I believe, 28 weeks. And they found that the infants in the women that had slept in a supine position had a gestational weight of 3,410 grams versus 3,500 grams in the women that did not. So there was a difference there. And the mean percentile was also, or centile rather, was also different. The study was limited by the power. So, I think we kind of have to take this information with a grain of salt, but definitely interesting to think about.
Yeah, it's really interesting. The thing that gets me about it though is, if this is actually truly relevant and there's a 10 percentile reduction in body weight, that shifts the curve. That can be a pretty big deal. The flip side though, it's only 57 women out of 760. So is this just a really small group? And this is just a random chance finding?
Yeah.
And, I think, pregnant women have so many things to deal with and so many things to feel guilty about already. I can't imagine trying to purposely pick a sleep position right now.
Yeah.
And I imagine with the physiologic and anatomic changes that happen in pregnancy that are already going to kind of force you to make changes, it's going to be tough already. And now to be, how many women are going to go to sleep and go, oh no, I can't sleep on my back. I can't sleep on my back. I can't sleep on my back. I don't know. I just don't want to torture pregnant women.
No, that's a great point. And I appreciate that too.
Yeah. So, we do what we can. Obviously, if it's an important difference, and, this is a meta-analysis, which is great, but it's also from case control studies, which have a lot of limitations, observational data, et cetera. So we'll see. I don't know. Hypothesis generating, I think.
Exactly.
Something to look into.
Yeah.
All right. So moving on to the next one. This is an interesting paper. We've actually got a couple. Ming Ding Wing is following us. Welcome. And Alex Pinero. Next up is the estimated association between organ availability and presumed consent in solid organ transplant. So in the U.S., most European countries, there is you basically need to opt into the organ transplant system. You need to say, I am an organ donor, sign me up. A lot of places, a lot of states, I believe Illinois includes, where there's a couple places where they prompt you, like when you get a driver's license. And but overall, the overall participation rate is pretty low. People actually consent to being organ donors. And a lot of people have suggested, a lot of data suggests that it's not because people don't want to be organ donors or are averse to it, but that you basically need that activation energy to make that choice. And so a bunch of behavioral economists have suggested, I remember reading a paper, or I think it was an essay in the New York Times by Richard Thaler from like 2009 about this a long time ago, where basically if it's ethically the same to opt in versus if it's presumed consent. So the default is that everybody consents and then you have the ability to opt out at any time. Those are ethically equivalent, but then people just kind of, people are generally lazy and you nudge people to being, the default of being organ donors. So what they did in this study was basically use the existing databases that we have from 2004 to 2014, the STAR waiting list, and basically do a simulation modeling with presumed consent and how many more people would be organ donors. You can show figure 1, which if I understand this properly, the bottom line is the random allocation. That's just kind of if, doing the simulation, kind of the lower bounds of how many people could potentially donate. And the ideal allocation on the top line is the upper bound if everybody got organs matched up perfectly. And I didn't exactly understand all the ways to describe things, but basically there were like thousands of person years lives saved.
Yeah.
And I think it was like 57% of people who ended up dropping out of the wait list in real life probably wouldn't have based on their simulation.
Yeah.
And dropping out usually means they either get sicker or die before they get transplant. So basically, again, if it's ethically the same, we could be giving a lot more people organs. It makes sense. Some European countries have switched to this kind of system, and based on their background, that they quote, that does generally lead to more deceased donor donations. Although they note there's some irony or the paradox where you get fewer living donor donations in some places because people are like, oh, I'm already an organ donor, I don't need to give somebody my kidney.
Right.
So it's interesting.
It is interesting, and I thought one of the things that they mentioned in the results too is they found that the amount of person years was particularly robust or increased in specifically kidney transplants and liver transplants as well, which is sort of interesting. The other thing that was kind of interesting was, and they referred to a prior study that had looked at, it was a survey, and they found that over 50% of U.S. residents actually support an opt-out type of consent. Yep. So there is some sort of inertia for that, but definitely interesting.
Yeah, absolutely. All right, so moving on, this is an interesting health policy RCT. So this is the effect of comprehensive care coordination on Medicaid expenditures compared with usual care among children and youth with chronic disease. So this was a Medicare Innovation Center funded study where they looked at Illinois Medicaid and randomized kids, the 3,000 kids in each group, or kids or young adults, with chronic disease like asthma, diabetes, sickle cell, seizure disorders, or they were former preemies. And did what's called the Coordinated Healthcare for Complex Kids, or CHECK program. They looked at it from 2014 to 2017. They did all sorts of things like, to address the social determinants of health, caregiver wellness, mental health needs. They had community health workers who helped them mental health services delivered by professionals, disease-specific health education, all that kind of care coordination stuff as opposed to usual care to try to see if that brought costs down. And unfortunately, it did not.
Yeah.
The good news is that the usual care group also had costs go down, and they actually think one of the main limitations was that Cook County, which is where Chicago, where we're in right now, during the study period, basically pushed a lot of people into Medicaid managed care programs.
Right.
So we'll probably diminish some of the difference that were happening and doing some of these savings. I think for me, every time we see studies like this, we see that care coordination programs just don't end up saving huge amount of money.
Yeah.
I'm still somewhat positive on it. I think part of it is that, the negative view, the pessimistic view is like there's not just magical money to be saved by taking better care of people, by better coordinating stuff. The plus side is usually we end up taking better care of people when we coordinate care.
Yeah.
It doesn't necessarily have to save money. Sometimes it costs money to take better care of people, and that's okay.
That is okay, yeah. I also wonder, in some of these studies, I think about we're looking at the short-term benefit, but I also think about the long-term benefit overall for our healthcare system.
Absolutely.
I guess one other thing I would mention about this RCT, just a minor limitation, is that unlike a lot of RCTs, not all of the everything wasn't spread equally among all the participants because sort of the services that were needed were predicated on what the patients needed, but minor. Regardless, still very interesting.
Yep, and also Illinois is a pretty blue state, so a lot of these patients are probably getting a lot of the services regardless, just not as part of the program. So it's harder to tell the differences between these two, which is tough. Got a couple more people joined us. Karsi and Mariam Name, or is that Name? Curious?
I'm not sure, but hi.
Welcome.
Yeah.
All right, tell us about our last paper.
All right, so this is the association between rotavirus vaccination and risk of intussusception among neonates and infants. And I guess I just really like thinking about rotavirus. But this was a systematic review and meta-analysis that looked at RCTs of neonates and infants that compared the risk of intussusception after vaccination with rotavirus vaccine versus a placebo group. And I think this kind of comes from some controversy or some discussion at least about whether or not there is this association between getting the vaccine and developing intussusception. So they looked at 25 RCTs with over 200,000 participants, and 33 countries actually too were included.
Yeah,
which is
4 continents.
Yeah, 4 continents, exactly. Pretty big spread.
Right.
They only found 20, and I guess the other interesting thing about this is they did a subgroup analysis where they looked at outcomes within 31 days of the vaccine, 1 year of the vaccine, and 2 years. They only found 20 cases within the first 31 days. 11 of those cases were among those that had received the vaccine. 9 were among the placebo. 74 cases within 1 year, 37 among the vaccine group, 37 among the placebo, which I'd never seen that before, exactly the same. And then 59 cases at 2 years, and 29 in the vaccine and 30 in the placebo. And so overall, they actually didn't find any statistically significant difference of developing intussusception with the vaccine versus placebo. So good news, I think, in terms of, promoting vaccination and knowing that potentially some of the adverse events that have been in question are potentially not there.
Right, and I think this is one of those good EBM stories because when the rotavirus vaccine first came out, like we talked about last week, there were a lot of concerns because for one, rotavirus gastroenteritis isn't fatal. Is it really worth it? It needs to be a pretty high bar. And there's some observational data that showed or that suggested that kids were getting more intussusception right after the vaccine. But of course, it's really tough because if you're getting the vaccine when you're a little kid, that's the age when you get intussusception.
Right.
So there's so many biases that can make that show up in an observational study.
Yeah.
So then there were a bunch of RCTs, and if you look at the figure, there's a forest plot that basically shows all these different RCTs of all the different vaccines, and they're all kind of like right around in the middle, and the overall rhombus is like almost exactly centered on one, which is always nice to see that there's no difference. But it's kind of nice to see basically over time, new vaccine introduced observational data that generated hypothesis.
Right.
Then there were some RCTs, a bunch more RCTs, and now a systematic review and meta-analysis showing no difference. So
exactly how
this
it's
is
supposed to work.
science at work.
Exactly.
Yeah. So it's really interesting. I unfortunately will have to say I don't think we're going to have any rotavirus papers next week.
Oh, man. All right. Well, maybe in the future.
Right. But thanks for joining us. We should be back next week, Tuesday at 3 p.m. Yet again. Listen to the author interviews as usual on the podcast. You can get iTunes or wherever else you get your podcasts. I think Androids do those too now. Get these papers and more at JAMAnetworkopen.com. Follow us on all the social media channels that you usually do: Twitter, Facebook, LinkedIn, Pinterest. Probably, I don't think we have a TikTok yet. And then thanks for joining us. Of course, papers will come out tomorrow, Wednesday, and Friday at 10 a.m. Central Time. Good.
Thanks, everyone. Bye.
Right. Take care.